Right. May we then move on, please, to the Corporate and NHS Performance Report. Karen, if I may turn to you first and give Matthew a couple of minutes relaxation before we turn to him.
Absolutely, but I won't be taking too long. The corporate part of this report normally covers our services, what we're doing inside NHS England and our major change programmes. And I've got nothing to bring to the board's attention on our services, but I did just want to assure you that we are continuing to make progress on improving many aspects of how NHS England operates, its core processes, recruitment, procurement, its governance and aspects that have been raised in the audit committee, and our staff engagement, which is really important. And we've just had the results of our staff survey, which indicate an improvement there of 4%, which I think is really positive, but more of that probably another time. Let me say then something about the national programmes. This report reflects the work that we've been doing to do a mid-year stock take on the progress and delivery confidence of all of our national corporate priority programmes. These are the 10 that we set out in our business plan last year. And I'm pleased that most of those are making very good progress, and that's particularly important as most of them get either closer to or actually in the stage of delivering real change on the ground, such as Callie was describing earlier with cancer. So that's very positive. Two of those programmes we've recently discussed at our executive group, Learning Disabilities and Self-Care, where we identified and agreed some further work that needs to be done to move them in a more positive way. The other thing that I did want to refer to was primary care services, which we discussed in some detail at the last board meeting. Again, we are continuing to focus, personally and many of my team are continuing to focus heavily on ensuring that we're putting all of the right effort in and working with Capita and holding them to account for improving the services that they are delivering. And I'm pleased that progress is being made. It's always slower to get out of a crisis than you would want it to be, but I am positive about the moves that are being made and about the contribution that Capita are making and their commitment to resourcing the services in the way that they do need to be resourced. So that is positive. I talked last time about a plan and timescales which we communicated with stakeholders and the board about the recovery timetable, and we are largely sticking to that timetable and plan. So improvements are being made week on week, literally, and I'm anticipating that most of the services will be largely fully recovered by March, with staging posts in between where we make good progress. You referred earlier to the performers list and the dental performers list in particular, and performers list continues to be a challenging area, but one where we and our medical teams in particular and our local primary care teams are investing a huge amount of time to ensure that GPs, dental performers and optom performers all get on the performers list in the timescales that we need them to. So a lot of work to do still, a lot of risk still there, but I think we are making adequate progress. I think that was it.
Thank you, Karen. May we pause there and invite any comments or questions from the board? Yeah, I have to say I'm reassured by what Karen has just said about primary care support. We were pretty disappointed at the progress on that when you reported earlier in the year. So I think we can take some heart from what we've just heard about the improvements that we're seeing. But I know you won't hesitate to alert us should there be any falling away from our expectations over the coming weeks and months.
Absolutely.
Jane?
It's in the report, but I just wanted to highlight the consultation that is out at the moment about the changes to services at Merseycare. So that's the old Wally site Calderstone's the only standalone learning disability hospital. Just encouraging everybody to respond, because that's really, really important and a major step in what we're planning to do with learning disability, where we continue to reduce the number of inpatients month on month.
Thank you, Jane. Right. Shall we turn, Matthew, to your part of the report?
Thank you. Yes. I really just wanted to talk about a couple of elements. I should start really with winter A&E and the pressures in the system. We are now seeing A&E performance has dropped to 89%, which is obviously below the 95% target. This is a combination of really three things that we need to jointly address. One of them is demand. As you'll see in the figures, attendance is up by 4.5%, admissions up by 2.7%. So we're seeing a growing pressure on the front door of hospital systems, whilst at the back door, delayed discharges rose to 200,000 days in the month. So we're talking about nearly 7,000 beds worth of capacity being held up by delayed discharges. If we'd said at the beginning of the year we were going to close 7 large hospitals, we would people would have thought that was a foolish decision. So we're taking a lot of capacity out of the system, and then there is always room for efficiency within the system of patients to be moved through more smoothly, get the care they need, and then moved on to the right setting. So the whole system is trying to work together. That we've got primary and community care, social care, and the acute trust together, trying to resolve the flow, which is why we're working very closely and every day with NHS improvements to say, look, this isn't a competition about who has the bigger problem. This is about how do you align in order to optimise for the patients. But I think the public can help us and help themselves a bit here as well. I guess the first question is, say, don't go to A&E unless you really need to. We have a set of other services. The most appropriate place for someone to go who needs advice is usually their GP, and so make a GP appointment, or ring 111 and speak to somebody who can give you advice, or use one of our urgent care centres, minor injuries units. And I thought it might just be worth sharing with the board the kind of the facilities that are available. It's worth knowing that 1.3 million people turned up to A&E in October. 1.2 million people rang 111. So the 111 service is taking as many contacts now as A&E did. And 650,000 people went to a walk-in service. And the 650,000 people went to a walk-in service. The compliance with the 4-hour standard for those services was 99.4%. So if you go to a walk-in service or a minor injuries unit, the probability that you will be in and out in a relatively short period of time is very, very high. And the nearest service to us here would be at Guy's Hospital down the road, and they were running at 99.9% in October on their turner, 4-hour turner. So there are other services, and they're not small services. They're taking half as many people are going to a walk-in service as are going to A&E. And we also know that half of the people who go to an A&E could have received their services in a walk-in centre or from their GP, or by going to a pharmacy. So if you don't know where to go, ring 111 and they will help guide you there. But if you need routine advice, you are better off, and you want it now, you're better off going to a walk-in centre in terms of your own time, and also not filling up our A&Es when what they need to do is focus on the people who need A&E care. And if we can take the people away from A&Es who don't need to be there and provide services for them elsewhere, then our A&Es will run better, and the people who desperately need the care we provide in an A&E will get that more quickly and more effectively. So the public can help the NHS here, and we think we have the set of services to help them help us. So I'd encourage that. I'll just move briefly on to elective weights, the treatments, access to surgical services, and the RTT standard. We're still sitting over 90% access within 18 weeks. That is exceptionally good by international standards, but we are seeing a pressure on access to elective services because of the pressure on beds from emergency services. So day surgery is going up very quickly, inpatient surgery isn't. So we have a risk that when we come out of winter, we will have seen waiting times go up because of the capacity taken by emergency. So very aware of that. And then the third final thing I'll just cover is preparation for winter. Work has now gone on across the country to ensure that we have GP and community services cover through the bank holidays, so that the right services are in place. These should be being advertised, local radio, local newspapers. You can find it by going to nhs.net if you want to know which GP practice you can get access to on Boxing Day. If you go to our website, nhs.net, or ring 111, they will guide you to the right services. We have made sure that people can get access to things that aren't an A&E department outside during the bank holiday period. And we've also made some quite significant investments over the last few weeks into primary care in order to strengthen primary care's ability to cope not just with winter but generally. So nearly £150 million has gone into primary care in sustaining improving investment in the most vulnerable practices, strengthening the areas where there is most need. So I think we have, the pieces are in place, but it's extremely busy. The hospitals are under a lot of pressure at the moment. Whole health systems are under pressure. And I think people are doing the best that they can.
Great, thank you very much. Jan?
Just a tiny thing. Matthew, would it be nhs.uk to go to find out where you're...
.net.
Yeah.
Okay, so www.nhs.uk. Thank you.
Very good point. Very good point. Thank you.
Matthew, sorry.
No, David. David.
Matthew, I think it's really interesting the comments you made about the scale and the availability of services outside of A&E. What proportion of the population do you think actually know about them?
Well, I guess given that more people use 111 or a walk-in centre than use A&E, somebody must know about it because we've got 1 million people. But that I think we haven't always made it as simple as we could to know which of these services you should call on, which is why we're trying to develop the telephone service as the right way of routing you to the care you need. So first, pick up a phone, make a call before you go somewhere, and we will try and make sure that you get access to the right services and so on. But the A&E brand is very strong. People know what's there. They know to go there.
My instinct is that it would be worth us thinking hard about whether it be social media, whether it be easy availability. I've just been on to one to see where they were by my own house. It's easy once you find them, you can see them. I think it would be really worth thinking hard, because my hypothesis would be it's not as well known, especially if it was linked to the point that you said, which is about if you go here, your service is X minutes, if you go there, it's Y hours.
No, I think it's a very fair point.
I have Victor and Joanne.
I'm just curious. It's come to Turning Point provides a service to a lot of people with complex needs, drug, alcohol, what have you. And I note that over Christmas, the numbers of people that are repeat A&E is significant in some of our services. I just wondered to what extent we're prepared, not necessarily for those people that get that very important message that you've just set out, but the people at the real sharp end of the inverse care law who are in and out of A&E multiple times, sometimes in the case of one day. And I wonder what work we're doing with organisations, not just Turning Point, but other ones, where we have a high proportion of highly complex substance misuse, mental health, or both, potentially homeless, but are heavy users of A&E. I'm curious about actually the proportion of A&E numbers that include those people, and I'm curious about what partnerships we are or could be creating to relieve the pressure on A&E, particularly over this period from that particular cohort?
Yeah, no, I think it's a really good question. I don't have numbers in front of me, but I think what we do know is that those very complex patients, whilst in head count numbers, they may not be enormous numbers, in the amount of time they spend in hospital, how difficult it is to discharge them once they've been admitted, those are very significant. And some A&Es have brilliant arrangements with the equivalent of Turning Point around the country to work in partnership with their mental health trusts, with voluntary sector, in order to provide the right input at the right time to those communities, and others less so, and particularly cities where it's a very transient population that just turn up in A&E. And it's part of what I would expect the partnership around STPs to be developing. That's why the conversation needs to be wider now, because we need to start to think about who are the most vulnerable groups, who are the highest user groups, and what is the right way of reaching to them. And it isn't always going to be done by the big hospital in the middle of the city. That's not frequently. That's not the service that those people need the most. If you intervene at the right time.
Do we have the numbers, by the way?
I sure we do.
Okay.
I guess I think people are often better than we realise at navigating towards the service that works for them. And that's one of the reasons why, as A&E gets quicker at processing people, it gets easier to be seen quickly in A&E than it does in one's GP. A&Es attract people who could equally well be treated in primary care. My experience with NHS Direct was that when we launched our symptom checker app, which was not promoted, 1 million people downloaded it within a matter of weeks because they found it, they told people about it, it was useful, they grabbed it. And so my question is sort of, how close are we to getting to the point where, rather than what you described just now, if you don't know what you want, pick up the phone, when we're going to get to the point of, if you don't know quite what it is that you want, go online, which is, after all, how most people address most questions these days. How close are we to being at the point of being able to offer people something really helpful for them online as a first point of contact?
Yeah, no, that's a very good question, because our wider approach to urgent and emergency care starts with an online presence, then it has a telephone presence, and then it has a set of places that you can go to. And with the honourable exception of what NHS Direct did a number of years ago, that online presence piece has been largely missing. So we have been doing a lot of work over the last few months, and we would expect to be piloting in a number of parts of the country an online experience forging in the next couple of months. And what we're planning on doing is looking at 3 or 4 different ways of doing it, doing a proper evaluation and saying which of these are the most effective, which are the public enjoy using, which ones give the best guidance to where you should go. I think the other part of that, though, is I think the online service and the telephone service have to live very closely together, because by definition your online service is going to be quite risk averse. So where are you going to put somebody who you think there might be something wrong with? The right thing to do is to get a clinician on who you can talk to about it, so that there's a streaming out of, okay, you've just got a cold, you're fine, but there's a whole middle area which at the moment the technology is moving very quickly, but at the moment the technology is not confident to just diagnose, or as we as the NHS need to do quite a lot of evaluation to be confident that that's the right thing to do. So it's getting it positioned in the right place, so we will have, in the next couple of months we will be starting to pilot that triaging and sort of adjusting the balance of who gets directed to a walk-in centre, who gets directed to A&E, who gets directed to a phone call, and who gets told you can just go to a pharmacy and sort yourself out. That balance is... And
if I may say so, I mean, let's not default to you need to go somewhere, wherever that is, because I think the experience is on many occasions people just need advice that they can look after themselves.
Yeah.
And that's a huge chunk, actually, and of course it's much better for people if they are able to look after themselves and not have to go anywhere at all.
Yes, I agree.
Very interesting question, isn't there, about the impact. I mean, I was quite taken by the figures that you gave about walk-in centres, for example, and the impact that channel shifting has on the capacity of real A&E departments to deal with the 4-hour
Yes.
expectation, because the change in acuity, and of course numbers of attendances are still continuing to rise. Just to reflect on that as we think about how to best measure.
And we have quite a lot of data around that, including if you can give an elderly person advice how to look after themselves at home, you can keep them in their home. If they turn up in an A&E department at 11 o'clock at night, they're likely to get admitted. So it's not a binary thing. And so intervening at the right time to help somebody stay in place is a lot better than trying to send them away from an A&E department at 11 o'clock at night, which tends not to happen.
Yes, I think it's a very good point. I have Jane, and then maybe we should draw this to a close.
Jeff, I just wanted to build on some of the things that Matthew said around, how are we trying to get some of those messages out over the winter? And one of the things that we've really done is concentrate very hard on helping people to help themselves for the reasons that Joanne's just mentioned. So particularly for the elderly, we know that we've got something like in excess of 25,000 additional deaths over the winter period. And so some of that is about preempting and actually taking action really quickly. So some of the messages we've been giving are, things like keeping warm and wearing different layers, having your flu jab if you're eligible for that, keeping your house at a reasonable temperature, and providing advice on how to access financial support to do that. But in terms of getting additional support, there are two really key things, I think. One is about going to see your clinical pharmacist, your local pharmacy, very early if you feel a bit unwell, because actually those are very highly trained clinical professionals who have something like between 4 and 5 years training, and actually can give advice on whether you need to see a GP or you need to be directed somewhere else. And then the other point that Matthew's talked about a lot, which I think is right, is about dialing 111. And the reason for that is many people, when they are faced with a problem, do not remember what services are available in various different urgent walk-in centres, and they're not sure whether they need an X-ray or whether they need to see a doctor. And some of them are nurse-led very well. So actually dialing 111 enables people to be directed to the right service. And I think if we can do those two things, that actually really, really helps people. Clinical pharmacy or 111 really makes a difference, as does actually trying to look after yourself at home, but getting help and getting support early rather than waiting until people become very unwell and then end up in an emergency department and need admission. So those are the real messages that we've been trying to give, as well as the really important one around if you've got elderly relatives, you've got elderly neighbours, actually just checking that they're okay. Just checking that they're okay and accessing support quickly. Those sorts of messages are really meaningful and actually are really having quite a positive impact on people out in the system who are recalling and remembering some of those messages that we're putting out.
Great.
Jane's been doing a lot of sofa surfing around the media of late, presenting the case to the public, which I think is really powerful, given that we now know that nurses are one of the most trusted professions in the public's receipt of information like this. It's good stuff.
Just on that last point, I guess that's the reason we now have Jane rather than Bruce.
Nobody trusts surgeons.
Overtaken medicine as the
Sofa surfing.
Nurses are at the top of the tree.
I think
Nurses
we should
are
be
more
grateful that we
trustworthy.
have two great talents that we
trustworthy
push
TV
out
face, that's what it is.
onto the breakfast time sofas. Can I just say, I think, thanks very much for that update, that in terms of the forthcoming winter period, which will be difficult across the NHS, it's worth drawing everybody's attention to the website www.nhs.uk.staywell. And on there is the performance by the Lewisham and Greenwich NHS Hospital Choir, which I have to say put into even more poetic measures the points that we've been making in the discussion today. So commend it to everybody. Great performance, and thanks to our comms team for having helped to organise.